So indication of a drug use in patients with CKD. So it's a busy table, but I mean generally when drugs are prescribed, so some drugs like insulin is obviously prescribed for diabetes. It's obvious, but some drugs like antidepressants or antibiotics could be prescribed for several reasons. So in the case of antidepressants, so this Quebec, Canada study suggested that antidepressants were prescribed only for 55% for depression, followed by anxiety for 18%, and insomnia or sleeping problems for 10%, and pain and 6%, and many other indications. And in the case of antibiotics, antibiotics may be prescribed for pneumonia or UTI or other infections. So sometimes researchers need to identify why drugs were prescribed, because this could be a kind of confounding factor in the study. So this Quebec, Canada database is very special in that every time doctors prescribe a drug, they need to input indication, every prescription. So in that case, identifying indication is very easy. But in most databases in the world, like CPRD and Japanese JAMDAC database, diagnosis and prescription are separate, so that we don't know which diagnosis is contributing to the prescription. So that a kind of strategy is needed to identify when is indication of a drug recorded in the database. So I found, in the case of antidepressants, I found a previous study comparing 7 European databases when the diagnoses are recorded for individual antidepressant prescription. And in the case of CPRD, if you look at only 3 months before and after the incident day of antidepressants, the proportion of indication recorded was very small, at 30%. But if you look back 1 year or 2 years or 3 years before, it's more likely to be recorded. Because doctor, once they input diagnosis, and they never record it again. So it's, I mean, different country by country and database by database. So some databases, every time doctors may input diagnosis. But in the UK, it's not, and I don't know in Japan. So according to this result, I decided to look back all the diagnosis records in the database to identify indication for antidepressants. And this is a result in patients with CKD who initiated antidepressants by type of antidepressants and major indication. So SSRI was prescribed for depression 63% of the cases, followed by anxiety 34%, and some neuropathic pain and off-label indication. Off-label means 適応外処方 in Japanese. While tricyclic antidepressants were prescribed not for depression and anxiety very often, but pain and probably sleeping problems or just sickness or some symptoms. So this is the result. And importantly, I compare this between patients with and without CKD. And importantly, this was not very different. So this is a kind of against my expectation. So I expected, in my clinical experience, I expected that antidepressants are prescribed for off-label or 適応外処方 in patients with CKD, but it was not in the case in the UK and in the real world practice, at least in the UK. So it's a kind of boring result. So to conclude the first paper, patients with CKD received antidepressants more frequently than age and sex-matched people without CKD in terms of both prevalence and incidence, while its reasons were not very different. So this is a result of a drug utilization study in my first paper. Okay. So do you have any questions or comments?
I've got a question.
Yeah.
Why did you think that the CKD population would have different indications for the antidepressants?
I mean, generally, I mean, we don't know. I mean, when patients with CKD say they are not very fine, they may be sick or they may be depressed, but may not be depressed, just sick, or tired, or so. If we use the same questionnaire, I mean, for depression,
Yeah.
patients with CKD may be identified as having depression because they answer to the question, they are tired and they are not motivated. So in that case, doctors may prescribe drugs expecting depression, but I mean, in the real world, I mean, it could be for just sickness. In that case, antidepressants may not be effective. So that's why I expected the difference, but it was not. Well, that could be because of just recording practice. Okay.
My question is, so when did you decide that you separate your drug utilization study and outcome study into two studies? So in our lab, so sometimes we combine it if the total information is not so very much, and sometimes so we separate it. So according to the situation. So at this, which point, which time point so you decided?
That's a good question. So first, to be honest, I was okay to publish it in one big paper, but the professor in the electronic health records, who is Liam Smith, always said that one paper should have one message. So in the middle, I found that my kind of objective was a bit different. I mean, the first paper is looking at the prevalence and comparing it in patients with CKD and without CKD. And the second paper was more focusing on patients, the side effect of drug. And in that case, comparison is not between patients with and without CKD, but comparison is between period with and without antidepressants. So if I put these into one paper, maybe reviewers may be a bit confused, or it's over the volume. So one paper can have only 3,000 words. So, but I know that sometimes it's criticized that one research is split into 2 or 3 to make more impact factors or something like that. But I think it's not bad idea to first publish drug utilization and then move on to the side effects or relative risk of drug in the case of pharmacoepi.
How did you define the diagnosis of depression or anxiety or some psychiatric algorithm or diagnosis in your paper? So did it validate or not?
To be honest, it's not validated. So just this time, I just looked at, used previous code list already published in previous studies conducted by psychiatrists. And so ideally, anxiety and depression should be validated. And also, I didn't talk, but I used not only diagnosis cause, but symptom cause. So in the UK database, there are kind of symptom cause, so not depression diagnosis, but just saying depressed. So this may not be diagnosis, final diagnosis, just patients were depressed and doctors chose depressed symptom cause. But if I excluded that the proportion and the prevalence was going down a lot. And previous psychiatrists using this database decided to use both diagnosis cause and symptom cause. Yeah, so that's of course, tough decision. But in this case, I didn't have time. Didn't spend too much because this was not my study outcome, but secondary outcome. So I just used previous studies.
Thank you.
Good question.